Hello, my name is Bob Gould. I am in the Department of Radiology at the University of California in San Francisco, and this talk is on CT dose reporting and tracking. So I think the first question we should ask is, why do we do this? Well, a lot of this is driven from concern over CT dose levels. Obviously, there was an event at Cedars-Sinai that made a lot of press. There were, in fact, 206 patients that were overexposed by CT. What is a little startling about this is this occurred over an 18-month period. That is, no one recognized what was going on for a full 18 months. This was a particular study called the perfusion study, and it means that you irradiate the same area, in this case, of the brain many times, and in this particular setting, and it turns out that there were other settings as well, the dose was about 8 times higher than it should have been. So it was a protocol setting error, but it made, as I said, a lot of news, and consequently was motivation, in fact, for a law that we'll talk about that was passed in the state of California. The other widely reported effect of, not really effect, but the widely reported in the press is that CT has been increasing substantially. So it now comprises about 15% of exams, but contributes fully 50% of the annual population dose from X-ray imaging, which is about 25% of the average annual exposure to an individual in the United States. So really, as a result of this publicity, there was a law proposed in California called SB 1237, which turned out to be rather poorly written, and consequently there were some clarification laws passed, namely SB 38 and AB 510. So these are all in effect now in the state of California, and they all have to do with CT dose reporting or incident reporting. So before we talk about that bill or the law in California, I think it's interesting to consider what we hear with increasing frequency now. A patient comes in and says, "What's my dose?" So it sounds like that should be a quick and easy question to answer, but in fact it's not a simple question, and we'll go through some of the reasons for that. In fact, we try to give an understandable answer to that question, but it usually involves generalization. So you give a typical dose for that particular procedure, kind of ignoring the particulars of an individual, that is, whether they're heavy or small, and things that would influence the typical dose mean that there is never a typical person. The other is we simplify, and we use what's called effective dose. We'll talk about that a little bit as well. But fundamentally, this question isn't about what's my dose. It's a risk-based question. So the patient really isn't asking whether they're going to get 3.2 millisieverts for a given procedure or 3.3. What they're really asking is, what are the likely negative consequences, or are there any negative effects from this particular procedure? So in other words, what are the risks associated with me having this CT exposure? Well, the risks are going to be dependent on the magnitude of the energy absorbed. That is, the magnitude of the risk of some effect, in particular usually cancer, will depend on the amount of X-ray energy absorbed by the tissue at risk. So they're asking the question, or the risk is associated with the dose to the tissue. So here is a very idealized phantom, uniform, and it's completely uniform. And what's drawn on that are isodose curves. So the isodose curves are lines of equal dose, where dose is defined as the energy absorbed per unit mass. So the actual amount of joules per kilogram. If it's 1 joule per kilogram, that equals a gray. A gray is a very large dose for diagnostic imaging. Usually we're talking in the milligray, thousandths of a gray level. It also is defined locally. That is, dose is to a point, not to a volume. And in fact, the dose is not uniform within a cross-section. So the dose distribution within a patient is going to depend on the particulars of the X-ray beam. It depends on the characteristics of the patient, the body part being imaged, and it depends on the attenuation characteristics of whatever is being imaged, or if there is, for example, a prosthesis of some type in that cross-section, that can affect the dose. So you see that in CT, for this very idealized phantom, there's maybe a 2-to-1 fall off between the maximum dose, which occurs at the surface, and the minimum dose, which occurs somewhere in the middle of the patient. So how do you answer the question for even this idealized cross-section of what's my dose? Because there's a twofold variation within that area, within that cross-section. So maybe a better question is there a critical organ in this cross-section, and what is the dose to that critical organ? That's very hard to get at. The easiest dose to get is the surface dose. We can actually put a dosimeter on the surface and work back, read out the dosimeter after the scan and figure out what the surface dose is, but that doesn't give us what the organ doses are within the cross-section. So going back to the California bill, they're saying that you have to report dose, recording of CT dose. So as of July of 2012, the dose of radiation on every diagnostic CT study produced during a CT examination shall be recorded in the patient's record. So this is the exact wording of the law. The CT studies done for treatment planning or attenuation correction in nukes are exempt from reporting, but all the other diagnostic CT studies apply. That is, the dose has to be reported or somewhere in the patient's record. So the faculty facility may send electronically each CT study and protocol page that lists the technical factors to PACS, and that frequently is done. So the other aspect to SB 1237, and this is also in effect now, is that the interpretive report of a diagnostic CT study shall include the dose of radiation. And you can do this either by recording the dose within the patient's report or attaching to that report a protocol page that includes the dose of radiation. So what do they mean by dose? Well, there are two definitions that they give in the law, and you have to report one of the following: either the CTDI vol and the DLP, or a dose unit recommended by the AAPM. Well, the AAPM has not made a recommendation, so that means you have to record the computer tomographic dose index with that, actually the volumetric CTDI and the DLP. Now, other talks in this symposium have defined these, so I will only do that briefly. But the reporting challenge is, just because it says put the CTDI vol and the DLP in the report, there's no explanation of how you should do that. For example, do you sum these for a given procedure if there are multiple series? Do you give it by each individual series? And what other information do you need to record in order to be able to interpret these values? Should you put the scan range in there? Should you put the phantom on which the CTDI is based? So none of this is clear within the law, and you have to, there is a frequently asked question, which you can get online, but by and large you have to figure this out. So as a guide, really, the University of California Dose Optimization and Standardization, called UC Dose, this is funded by the Office of the President. It involves all 5 UC medical centers. And the idea behind this is that all 5 centers would consistently report the CT dose. In other words, respond to the bill, SB 1237, and its derivatives uniformly. This UC dose guidance document is available, and here's the reference. Or you, in fact, can just Google UC dose guidance, and it will come up, and it's easy to get to. So here is what this consortium of 5 schools came up with. So it said to give the CTDI vol and the DLP for each series, so not to sum them. You don't include the dose from the SCOUT or the topogram, because this is so small in comparison to the other. It's really a very small dose. You have to include the phantom size that's used in the calculation of the CTDI vol, so that that number is more interpretable. And you should include the anatomic area that's imaged, so head, neck, chest, and so on. So again, you do not add the CTDI vol and DLPs from different series. And the reason for that is shown here, very idealized. So here, for example, is a dose report for a procedure that involved 5 separate exposures. And the colors shown here represent each series. And you see in some cases they overlap, and in some cases they don't overlap. So all these sum together to give a CTDI vol that looks like this dotted line. So it really isn't consistent. There's no way of appropriately adding either the CTDI or the DLP in this particular study. So rather than do that, it's best to report each series individually. So that said, there may be times when adding the CTDI vol may be appropriate. For example, when a large anatomic area is scanned multiple times. So pre- and post-contrast head would be an example of that. There may be, certainly are situations where the CTDI vol should not be added. It's not appropriate to do that. And a good example of that is where you're scanning the same area over and over again. For example, in a perfusion study. Because the CTDI vol, by definition, includes scatter from adjacent slices. So you would significantly overestimate the dose to that particular region if you added the CTDI vol. So rather than try to figure all this out on when you should or shouldn't add, it's best to just report them separately. So you also have to address what happens if a patient has multiple exams at the same time. And the best example of this, or a good example, is the chest abdo-pelvis. So here are 3 separate regions of the body being imaged, all at one setting. And it may generate different interpretive reports. For example, at my institution, we would generate 2 separate reports for this, one for the chest and one for the abdo-pelvis. However, the dose is to be reported as a single summary, even if these separate interpretations are generated. So then the summary report may be included in both of the interpretations or referred to by one of the interpretations. But in any case, it should be made clear that the dose report is duplicated. That is, it represents the dose for all of the entire exam. The other piece that is recommended is that there be some explanation of the dose indicators, CTDI-vol and DLP. We know that CTDI-vol, for example, is not patient dose, that it can over or underestimate the patient depending on the patient size. It tends to overestimate dose in large patients and underestimate dose in small patients. Remember, the CTDI-vol is really measured in a plastic phantom and is a very precise measurement when done correctly and very reproducible, but it's for a plastic phantom and not for a patient. And the DLP, of course, depends on the CTDI-vol. It's just the CTDI-vol times the scan length. So this very complex slide is to show what UC San Francisco is currently using as their dose reports. So it says what the patient is. It says patient so-and-so received the number of series that you're going to report on during this particular CT study. Then for each of these exposure events, it gives the anatomic area, it gives the phantom that's used, and it gives the CTDI-vol and the DLP for that particular series. So it merely lists them all out, and then it tries to put it in context, explaining a little bit about CTDI-vol and the DLP, explaining that these are not patient dose, but it also gives a website, which is our website, which has dose information for patients who want more information about those measures and about dose in general. So what about image-guided procedures? And unfortunately, this is one of the areas that is not particularly clear in the laws, but California does not exempt these from having dose reporting requirements. And sometimes these can have in excess of 20 series, these exposure events. So that would make for an extremely long dose report if each series was reported. So all of the exposure events are usually of the same or nearly the same anatomy. So the Department of Public Health in California has given some clarification on this that says if there are multiple sequences of more or less the same body part, you have some choices as to how to report that. You can report for each CTDI and DLP for each series. Again, that would make, in many cases, of a very long report. Or you can report them summed. In this case, that's probably appropriate. Or you can report the highest CTDI-vol and the DLP and give the number of sequences to which these numbers apply. So they also say that you don't have to be consistent. That is, you can report the CTDI-vol in one way and the DLP in another. So that greatly simplifies the report. So the other challenge, though, is to get these values into the dose report. So the machines typically generate this. It includes the information for each series as a screen capture, which can be sent to PACS, and therefore viewed when you're viewing the images. However, because it's a screen capture, it means that it isn't searchable. There's no way of extracting that information except possibly with character recognition, but you've got to send the report somewhere else or that particular screen capture to a device that can do that. So unfortunately, the CTDI-vol and the DLP are not required parts of the DICOM header. So you can't simply extract it from the DICOM header. But one way you can get these into the report is simply dictate it. If you have a template and a voice recognition system, you simply fill in the values. It's a little, clearly, when you're doing this and reading the screen capture, the dose report, along with the images, you need to be careful or you can introduce errors. The better way, though, is to have this automated. And this has been done by a lot of the servers now, enable you to introduce this automatically. So they either calculate, use optical character recognition or the DICOM structured report to obtain the CTDI vol and the DLP, extract this, and then through HL7 messaging can insert it into a template. This is a little tricky because formatting can be problematic. And there are also problem studies where there are too many exposure events. So you have to be careful doing this, but it is certainly possible to automate. There is this DICOM structured report I just referred to, radiation dose structured report. It's produced by a lot of scanners now, certainly by the new scanners, current generation of scanners. It's stored on many packs, but almost never viewable on packs because it's really an information page. And the way normally you view the data is through that screen capture, not by viewing the structured report. However, the dose servers that are available, of which there are 5 or more available out there that will store and in a database the doses from various CT studies on a given patient. So these usually can interpret that DICOM structured report. However, this needs further development and better implementation. So what's going to happen? Well, in the near term, within a year, there will be widespread implementation of size-specific dose estimate as opposed to just the CTDI. Again, the California law doesn't mention SSDE, so it would be left to the AAPM to say, okay, this is a sanctioned unit, and then in which case you could report it. So this is going to be calculated even at the scanner level, but possibly definitely by these dose servers that I referred to. And in years to come, I think there'll be better methodology to extract specific organ doses as opposed to just the CTDI vol, and a better estimate of effective dose. Thank you.